This is Tada from Sendai Kousei Hospital in Japan. Today I would like to talk about TAVI after AVNeo. This is my COI. So today I will talk about these three topics. The first one is TAVI for AS after AVNeo. I show you a case published in European Heart Journal case report. The patient is 80 years old lady. Her height is 139 centimeter and 48 kilogram. So very small body. When she was 74 years old, she underwent AVNeo for severe AS. This is her operation record. The clinical diagnosis was aortic stenosis, and her annulus diameter was 70 millimeter. The operator, Kazuo Abe, underlined 70 millimeter. He emphasized that the patient was small aortic annulus. Aortic valve was tricuspid and degenerated. He dissected the cusp and sutured the aortic pericardium. The size was 23 millimeter in all cusp. The operation time was 4 hours 26 minutes. The follow-up echo data shows mean pressure gradient was 25 millimeter Hg before discharge and 18 millimeter Hg at 6 months after follow-up, after operation. However, she didn't come to follow-up after that, and 5 years passed. In 2017, she presented short of breaths and come to our hospital and shows that recurrent severe AS. This is simultaneous pressure measurement during TAVI. It showed severe aortic stenosis. And this is CT and TE. The leaflet were elongated, long, and thickened, and marginally calcified. Their mobility was decreased. That produced severe stenosis, aortic stenosis. The valve leaflet was sufficiently long to reach the both coronary artery. So our heart team discussed about her management. The redo heart valve surgery would be of high risk. Euro 2 score was 7%. And at that time, Dr. Abe left our hospital already, and another surgeons performed several cases of redo AVR after the AVNeo failure. And he does not feel good of her redo surgery after AVNeo. And the second reason is the aortic annulus size was small. Therefore, TAVI seemed to be better to achieve larger effective orifice area. And the third one is using next generation TAVI valve such as Sapiens 3 or Evolute. TAVI had become stable procedure at that time. We measured the aortic complex using CT. Annulus size was 335 millimeter square. According to the sizing chart of Sapiens 3, it is a border size zone of 20 millimeter and 23 millimeter valve. The coronary height was 12 millimeter in right and 12 millimeter in left. In general, lower than 11 millimeter is thought to be high risk of coronary occlusion. However, both sinus of Valsalva and the STJ is small, and the leaflet is long. So we consider that this is a high risk of coronary occlusion, and we performed TAVI under coronary protection for both coronary arteries. This is aortography at TAVI procedure. Aortic valve after AVNeo typically shows that leaflet falls into LV and reverse to aortic size. In this particular case, valve opening is very small. This is just before valve implantation. This is Sapien 3 valve, 23 mm. We protected both coronary arteries. This is right, this is left. It is very rare to do coronary protection for both coronary artery. This is just a moment of implantation of Sapien 3 valve. This is aortography after Sapien 3 implantation. Both coronary artery was patent. Aortic regurgitation is mild. She is doing well after TAVI, and recently she came up for 4 years follow-up, and valve function is still good. The second one is the next case is TAVI for AR after AVNeo. This is 87 years old male, and he underwent AVNeo 8 years ago. This is his operation record. Clinical diagnosis was aortic stenosis due to bicuspid valve. This is type 1 bicuspid valve. LCC and RCC was fused. The size of reconstructed leaflet was R is 29, left is 29, and non-coronary cusp is 35 millimeter. After surgery, we follow up the echo. Echo shows torbial AR by 6 months and mild AR by 7 years. However, LVDD was gradually enlarged. At the 8-year follow-up, echo showed moderate AR, and 8-year 1 month, he developed congestive heart failure, and echo showed severe AR. This is TTE, 8 years 1 month after AVNeo. Left ventricle is enlarged, and LV motion is preserved. Several directions of AR jet was seen. This is TEE at the time of TAVI procedure. Non-coronary cusp leaflet was large, but other leaflet was small and didn't move so much. In diastole, non-coronary cusp was prolapsed into left ventricle, but others did not, which produced AR. 3D CT also showed asymmetric leaflet motion. Only non-coronary cusp were large and other leaflet was small. CT measurement for TAVI procedure shows that annulus area was 532 mm square. It is a borderline of 26 mm and 29 mm. We chose 29 mm. The sinus of valsalva measurement was 34 for right, 34 for left, and 40 for non-coronary cusp. Only non-coronary cusp was big, This was due to type 1 bicuspid. Coronary height was high enough, and RCC and LCC looks very small. So we thought that this is no risk of coronary obstruction. We implanted Sapiens 3 29mm width without coronary protection. Our aortography before Sapiens 3 implantation shows severe AR, and after TAVI, there is no AR. Six months after TAVI showed no AR. So I summarized technical consideration about TAVI after AVNeo. First one is coronary obstruction. This is a case of coronary obstruction for TAVI using Sapiens 3 for native AS. You can see left coronary artery, but in the sinus, coronary construct was transparent. It induced myocardial infarction. The reason is the several calcification volume of left coronary cusp. So you can imagine that the risk of coronary obstruction is not only coronary height, but also the calcification volume of the cusp, and also small sinus of Valsalva, because it's a space of the leaflet after TAVI. There are some risk coronary obstruction. This prediction model was published recently and said that coronary obstruction, if cusp height is over than coronary height and virtual valve to coronary distance is less than 4 mm, or culprit reflect calcification volume is over than 600 m3. It's simply to say coronary obstruction occurs the combination of low coronary height, small of sinus of Valsalva, and high calcified valve. I can say TAVI for AVNeo itself is not a risk of coronary obstruction because leaflet is not calcified. The coronary obstruction in TAVI for tissue valve is different mechanism. When TAVI valve is implanted in surgical valve, tissue valve itself cover all around. So blood flow is not transversely. We need to consider whether blood flow from STJ is maintained. So the size of STJ and SOV is a big key for coronary obstruction for TAVI in SAVA. VTC and VTSTJ are parameters to predict coronary obstruction in TAVI in SAVA. We put the virtual circle of TAVI valve into SOV and STJ, and we measure the space at SOV and STJ. The space between this circle to coronary ostium, it is called VTC. And the space between virtual circle and STJ, it is called VTSTJ. In case VTC less than 4 mm and VTSTJ less than 2 mm, this is a high risk of coronary obstruction. So risk of coronary obstruction for TAVI after AVNeo, I think it's not in general, it's not a risk of coronary obstruction because leaflet is longer but less calcified in general. In contrast, we need to consider about the size of sinus of Valsalva and STJ. And if there is high risk of coronary obstruction, we can manage assess and overcome, because we can do the technical management such as coronary protection and bailout stenting. The second one is AR after AVNeo. Currently, the guideline shows AR after for TAVI is still not indicated and controversial. And in contrast, TAVI for tissue valve regurgitation, it's a class 2A indication. Off-label use of TAVI for pure AR is well summarized in this paper. Using these second generation TAVI device shows better outcome as compared to using early generation device. However, even though using second generation TAVI device, this event rate is not low, such as second valve implantation is 12%, aortic regurgitation is 4%, absence of device success is 18%, pacemaker is 18%, and 30 days mortality is 9%. One reason, biggest reason, why TAVI for pure AR is difficult is oversize ratio. Because in general, TAVI valve is anchored at the valve position using the calcified AS leaflet. However, AR leaflet has no calcification. So in order to fix in the position, we need bigger device. This is sizing chart for a native AS. And this is the sizing chart proposal for pure AR. For example, Sapiens 26mm is range from 430 to 540. But for pure AR, they propose sizing range from 370 to 470. So the optimal oversize ratio in TAVI for AR after AVNeo is difficult and unknown problem. We need bigger size because the leaflet is not calcified. Or it should be the same as native AS because annulus was calcified if it used to be AS. Or because annulus is thin tissue due to the debridement of annular calcification. The third one is annular splaying. This is a schema of aortic valve complex. In the field of TAVI, annular splaying is defined as connecting the three hinge points at the bottom of aortic sinus, which is called virtual basal ring. In native AS, virtual native basal ring is just the bottom of the aortic sinus. However, in AVNeo, leaflet going down and going up, so we confuse whether virtual basal ring is bottom of the leaflet or bottom of sinus. For example, this is the case of AS after AVNeo published in the European Heart Journal case report. We thought at that time, we thought the virtual basal ring was bottom of the leaflet, and annulus area was measured at 335 mm square. However, when we measured at the bottom of sinus, here and here, it was measured as 290 mm. This is a range of Sapiens 3 20 mm. And after implanted Sapiens 3 23 mm, it looks like incomplete expansion like here. So now I can say that we should have chosen 20 mm valve. So it has defined, we should define basal ring as here, bottom of the sinus. The fourth one is implantation depth. Implantation depth is recommended just 2 or 3 mm below the virtual basal ring. However, again, in the case of AVNeo, which is better? Just below the leaflet as here, or just below the bottom like here? Implantation depth is a trade-off relationship, because higher implantation it's a cause of a risk of coronary obstruction and the difficulty of future coronary access, and lower implantation is a cause of conduction disturbance and pacemaker. Actually, in current field of TAVI, higher implantation is trend to avoid pacemaker implantation. These three cases is different implantation depths. The first one is ACIA after AVNeo. As I showed before today, it's low implantation. The B is AR after AVNeo. This is also I showed today, and this is also low implantation. And this is a case of TAVI for AR after AVNeo and the David compilation. Today I don't show a detail today's talk, but this is high implantation, and it looks very nice to me. The last topic is device type. There is two device type in the TAVI field: balloon expandable or self-expandable. The choice is the case by case, but in general, this is operator's preference. In balloon expandable valve, we can say that it's easiest to manage coronary artery because the height of the valve is low, and there is the big cell to go through the catheter, and compatible to large valve. And the valve leak is generally small, but a size error may induce adverse event because we need force to inflate the valve. In contrast, self-expandable valve, it's no injury to aortic lead because it's self-expandable, and we can do recapture and repositionable. It's good, very good for the control the implantation depth, but difficulty to coronary management because it's high valve and cell is very small. So this is my last slide. My lesson from TAVI after AVNeo is I think it's feasible. The coronary obstruction is not a huge risk. I think it can be managed. However, it's still difficult to manage oversize ratio and implantation depth. My limitation of my experience is I have no experience of self-expandable valve. That's all. Thank you very much.